Hi, Dr. John Alchemy with RateFast. Today I'm here to talk to you about something interesting that I particularly enjoy and that RateFast is actually built around. And that's the concept of adjusted pain values and tracking objective recovery to maximal medical improvement. Um, Tracking someone and determining them to be maximally medically improved has been more of an art than a science up until RateFast got involved with it. But typically, the way that the workers' compensation system works is someone gets hurt, they receive treatment, the doctor makes a determination that they arrive at maximal medical improvement, meaning we're not anticipating that they're going to get any better within the next 12 months with or without treatment. And at that time, the doctor is required to deliver within 20 days a report known as a permanent and stationary report, or a PR4 report in California. Now, the question always comes, and I think a lot of doctors can sympathize with me on this. A lot of adjusters can sympathize, and of course the patients. When is the case going to be over? Okay, how long is it going to take, and how do we know when we get there? And that's the main question of maximal medical improvement. I can't tell you the number of letters I get from insurance adjusters saying, when is this case going to be MMI? Why isn't it MMI? Dr. Alchemy, tell me when this is going to be over, essentially, is what the adjuster wants. Patient wants to know the same things. What do I have to do, et cetera, et cetera. Well, if you understand the concept of recovery and the concept of what underlies all impairment reports, which is the functional recovery or the activities of daily living loss, and you read the AMA guides, and you understand that the AMA guide says on page 20 that two measurements are similar if they're within 10%, and the converse is obviously true, that they're dissimilar if the difference is more than 10%. That is what the AMA guide sets as its standard of difference, 10%. And if you look at a case, the main things that control impairment and recovery, so the impairment score at the end of the day, that number between 0 and 100% whole person impairment, again, 0, totally fine, can do everything I want, no loss. 100%, I'm bedbound, I'm on life support, everyone has to do everything for me, 100%. That number, okay, is nothing more than a reflection of the loss of activities of daily living, of which there are 34 in table 1-2, page 4 of the AMA guides. You have to make that connection. You have to understand that whole person impairment is activity of daily living loss. And once you've done that, you will have now unlocked understanding to how to track someone for maximal medical improvement. Now, tracking someone on maximal medical improvement is very simple once you understand the underpinnings and how to do it and decide upon the path to do it. Now, the most simple way for tracking someone on recovery is to use what RateFast has developed, known as adjusted pain value, or the APV. And the APV is nothing more than a 4-digit code that all injuries share in common. The first is the scoring of 0 to 10. Typically, we think of this as the analog pain score. It's got a picture of a smiley face at 0 and a frown face with a couple of teardrops at 10. And somewhere in between is where you are. Sometimes you're at one end of the spectrum or the other. But for the most part, you're in there between. You have a pain score. Now, if you have asthma, maybe it's a symptom score. Maybe you're not having pain, but you're not breathing well. If it's a vision problem, it's not a pain score. It's a functional score. 0, I can see everything with great vision 20/20. 10, I can't count fingers or even determine if there's light in the room or not. So, but every body system has a scoring between 0 and 10 that can be achieved. So that's the first thing in creating the APV. And the APV, again, is going to be a single number that we will reduce between 0 and 10. Do not confuse the APV with a pain score of 0 to 10. The pain score is just a subset of the APV. Next, after the pain score, or the symptom load score, 0 to 10, we have frequency. How often are the symptoms present? Are they all day? Are they half the day, a quarter of the day, 3/4 of the day? So we then assign it a frequency, 50%. Next, we look at activities of daily living. What is your score of activities of daily living? In prior pod and video casts, I've talked about APVs, I've talked about functional loss, and I've talked about activities of daily living. And activities of daily living are split into two groups. One is I can do the activity, but I have symptoms. And two is I can't do the activity with or without symptoms, meaning I can't walk, like I used to before I got hurt. I can't stand as long. I can't lift as much weight. This is something I can no longer do that I could do before I was hurt. And that's what we refer to as a broken ADL. So to create the APV, we have, again, a pain score or a symptom value, 0 to 10. We have a frequency. We have an ADL count of pain only, meaning activities can be done, but they have symptoms. And then we have ADLs broken, meaning that the activity is slowed, either in its rate or duration in which it can be done. And once we have those four things, then they are created into something called the APV using our patented method. Once we have an APV, that is a number that is reduced down to a single digit between 0 and 10 again, because that's where people understand things. 0, very good, 10, very bad. And so once you have that number, okay, you can calculate that at every point in the case, every PR2, every supplemental report, every time the doctor sees the patient, an APV can be calculated. Now, to make things a little bit easier, one change between a 0 to 10 pain score is 10%. So we know that if someone is improving with their APV and they're getting better by 1 point of the APV between every 6-week visit, okay, we can tell if they're actively recovering or not. Now, the reason this is important is people don't think this way about determining MMI. If we had the right tools, if we understood how to do the math, I would never get that letter from that insurance adjuster. When is this case going to be MMI? Now, I don't expect them to understand this because this is somewhat advanced, but the concept is very simple. We simply track mathematically if you are getting better. If you're moving in increments of 10% every 6 weeks, you are under active recovery and your case is not ready to be rated. Now, remember, this gets a little complicated, and I talked in another video podcast about multiple body parts, okay? And this is why I do not advocate that we wait for all body parts to get MMI, because they arrive at MMI at very different times, and getting a case rated and tucked in and completed is very important to efficient and complete settlement for a case. Now, going back to this, sometimes people are getting worse. You need to know when that's happening too, because they are not getting closer to MMI. They're actually getting farther away from it as far as an anticipated recovery, okay? So they're going like the opposite direction, okay? And remember, it's maximal medical improvement. It's not maximal medical worsening. So if a case is getting worse and not better, you really have to ask yourself, is this case ready to be rated now? Now, that has to be balanced with a couple of other things about MMI, and I've also talked about these before. Has the individual successfully received all the treatment that they should have, or all the treatment that's available, or all the treatment that they're willing to accept, okay? And is the individual's measurements getting any better? Are the ranges of motion getting better? Are they getting stronger? Is their gait improving? Is their vision improving? Has their hearing improved? All of these things. Pulmonary function test, is it getting better with treatment? So you have all these different things that you're watching about people's recovery. But of them all, the most important is the APV, because that is their true activity recovery that needs to be tracked. And so basically, if someone is hitting flat, and the APV is nothing more than tracking something on a line, and we're looking at the slope of the line. It's very simple. And if the slope is negative, meaning that they're going from a higher APV to a lower, they are getting better. If it's positive on that slope, then they're going the wrong direction. They're actually getting worse. And once you reduce the analysis of maximal medical improvement, impairment tracking, using these methods, there's no more guessing. It's very straightforward. And you'll know exactly when they'll arrive at MMI. And in fact, if you used advanced analytics, you can calculate and anticipate when that slope is going to flatten. And you can know your date of MMI in advance. And you can see their rate of recovery. Let me give you an example. Someone comes in with an APV of 8 on their back, and you get them treatment and some therapy and a couple of medications. You recheck them in 6 weeks. Their pain has gone to a 3. That is a very steep negative slope on that recovery, meaning their recovery is rapid and very vigorous. Now, maybe in the next 6 weeks, they go from a 3 to a 2, okay? So they've had a 50% recovery from an 8 to a 3, and now they're going from a 3 to a 2. Their recovery slowed down, but they've still dropped 1 point, still 10%. And that's within the AMA Guide's understanding of something that is different, not the same, and therefore recovery is ongoing. Now, we see them again in 6 weeks. They're still at a 3. We see them again in 6 weeks. Maybe they've done chiropractic or acupuncture or something else. They're still at a 3, okay? We can be pretty comfortable that this individual is getting very near or has already arrived at maximal medical improvement. And again, we're using technical, objective data and analytic standards to make the determination. Because what you really don't want, what you want to remove, is the subjective opinions that someone is at MMI. You want to be sure that they've arrived there. Because if they haven't arrived there, all you've done is you've kicked the can down the road, and it's going to come back later because they're not actually medically improved. They're not maximally medically improved, and the case should not have been rated, okay? And so once you have insight into that, you have a much better understanding about how long is this case going to go on? You know, what's the patient's real recovery going to be? How are they really going to respond? And you can also use this information if you're a physician or a claims adjuster when you're talking to the injured worker to give them context and say, look, I'm not trying to rush you out of your claim. I'm not trying to deny you treatment, but all we have to look at is what you report to us every time you come in. This is what you say your pain score is. This is what you said the frequency is. This is what you told me your activities of daily living are. The math is very clear. You're not getting any better. And it's time to do the impairment report, get settlement, and help you kind of finish up and figure out what the next step is beyond your work comp injury. And so that's just a very brief overview of the power and the value of activities of daily living, pain scores, and the RateFast proprietary and patented adjusted pain value. I hope this has been helpful. I hope it helps you think about impairment rating, reaching maximal medical improvement in a new and different way. Again, I'm Dr. John Alchemy with RateFast.